As you heard in previous videos from Dr. Aurora and Dr. Twitty, we believe that higher doses of nimacimab must be assessed in future clinical trials to evaluate the weight loss potential of nimacimab as a monotherapy and even in combination with GLP-1 therapies. It's important to note that this is not unusual for large molecules like monoclonal antibodies across multiple indications. You only need to look at 2 other monoclonal antibodies in development today for the treatment of obesity and overweight. In the case of Eli Lilly's bimagrumab, they evaluated doses as low as 10 milligrams per kilogram and as high as 30 milligrams per kilogram. For a 100 kilogram individual with obesity, these doses work out to be approximately 1,000 milligrams and 3,000 milligrams of bimagrumab. In a less extreme case, MariTide, a monoclonal antibody with dual-acting activity, dosed as high as 420 milligrams. In our upcoming clinical trials, we expect to evaluate doses of at least 600 milligrams and potentially as high as 1,800 milligrams. With this being all said, we still need to solve the problem of how we are going to deliver such high concentrations of drug through the skin as a subcutaneous injection. While what I said is true that most antibodies do require high doses, many of these drugs are delivered intravenously and not subcutaneously. The reason for this is because historically, high concentrations of antibodies in formulation can be quite viscous or thick, which makes it very difficult to inject. Alternatively, if you keep the concentration low so that the formulation is more fluid and easily injected, then you would require very high volumes, which would also be very difficult to inject. In the next couple of videos, I will lay out how Skye plans to subcutaneously inject high doses of nimacimab while avoiding the viscosity and volume challenges normally faced by monoclonal antibodies.